Hello, I am Stan Rockson from Stanford University. I'm here to speak about the treatment choices for lymphedema and lipedema. We'll start with lymphedema, the much more common problem. The approach to the treatment of lymphedema is based upon the principle that the earlier we can intervene, the more we can arrest the tissue changes that represent the progression into the latter stages of lymphedema. This is conjectural. It has actually never been proven, but certainly is a mandate to undertake aggressive intervention as soon as the diagnosis is established. The mainstay of treatment has typically been called complete decongestive physiotherapy. It's a multimodal approach that is designed to reduce the limb volume to its attainable nadir. It includes a specific lymphatic stimulation technique or massage technique called manual lymphatic drainage, and this is typically used to set the stage for the mainstay of the treatment, which is multi-layer bandaging. This is not a compression bandage, but simply a compartment that is applied to the limb that when exercise or physical activity is performed with the bandaging in place will augment the contractility of the existing lymphatic circulation and help to clear the protein-rich lymph from the tissues to allow the limb to decompress. Repetitively, this is performed over approximately 4 to 6 weeks. In the United States, we typically do this 3 times a week, but if feasible on a daily basis would be even more desirable. And eventually, the goal is to fit the patient with an elastic compression garment that can be worn in the maintenance phase of care applied by the patient on a daily basis to prevent reaccumulation of the edema fluid. There are now a variety of such compression garments on the market so that in addition to the tubular stockings and sleeves that have been conventionally employed since the time of Dr. Jobst, we now have Velcro-stayed compression wraps that can be employed on the upper extremity and the lower extremity that provide an alternative for those that are not able to mechanically manage the elastic tubular garment that must be pulled over the extremity. We have a variety of nocturnal compression garments that can be employed for those patients who reaccumulate excessive edema volume even during recumbency. We also have a variety of pneumatic compression devices. These devices are not intended to be an alternative to the decongestive approach already described, but rather an adjunct that can be used either in the acute treatment phase or in self-management by the patient during home use. There are a variety of devices on the market. There are simple devices that either have single chambers or multi-chambers providing a gradient, but these are non-calibrated and non-programmable. And we also now have advanced devices that are multi-chamber, provide a pressure gradient, are calibrated and programmable to allow for the most physiologic stimulation of lymphatic flow achievable through an external device. The other alternative for these patients is surgical. One of the surgical interventions that has proven to be extremely helpful for the latter stages of lymphedema is so-called suction-assisted lipectomy. This surgical approach now has a greater than 20-year history, with many thousands of patients throughout the world having undertaken this procedure. The approach is to remove the fibrofatty accumulation that occurs with long-standing lymphedema to restore the limb to a more normal volume, because at this stage of the disease, no amount of stimulation of lymphatic contractility or external compression will in fact decompress the limb, because the edema is based upon structural overgrowth and not the presence of fluid alone. Once the edema has been reduced through this surgical means, it must be maintained through the rigorous use of a compression garment perpetually. But these patients, when successfully operated and when compliant with postoperative garment use, can retain normal limb volume over years and even decades. There are a variety of microsurgical approaches that have been proposed and increasingly employed over the last 10 years. One of these is lymphovenous anastomosis, which allows for diverting of lymphatic flow into the adjacent venous circulation. The second approach is vascularized lymph node transfer, which will allow the auto-transplanted lymph node to orchestrate lymphatic repair in the limb that is damaged. In both cases, we do have reports of significant improvement in edema volume and improvement in quality of life, but large-scale prospective analysis and long-term follow-up of these surgical procedures still requires further attention. For lipedema, the treatment choices are relatively quite limited. In fact, we have no medications for lipedema. We have no conventional non-surgical approaches. It has been posited that people with lipedema have difficulty in clearing fluid from the subcutaneous tissue, and that this is the pathogenetic mechanism that allows the adipose cell to become edematous and eventually overgrow, as it does in lipedema. So one could postulate that use of low-grade compression in these patients might help to slow the progression of the disease. This has never been demonstrated conclusively, and furthermore, because so many of these patients have pain, it's very difficult to get them to wear compression garments on a regular basis. We do have one surgical intervention that has been proposed and been utilized successfully over the last several years, and that is so-called tumescent liposuction or lymphatic sparing liposuction. This is distinct from the dry liposuction that is performed for lymphedema, where the lymphatic vasculature is presumed to be destroyed and no longer requires preservation. In lipedema, we think the conduit vessels are intact and we don't want to destroy them surgically, but with tumescent liposuction, we introduce fluid into the subcutaneous space, which agitates the adipose cells from the surrounding environment, allows them to be disrupted, and then the material, the edema material, can be withdrawn in a standard liposuction approach. This allows for recontouring of the limbs. It is not considered and should not be considered as a cosmetic procedure, but it does help to alleviate the discomfort associated with lipedema, allows a return to a more normal or approaching more normal limb contour and size, and most importantly, can help with difficulty with mobility in these patients who have very deforming lipedema at the latter stages of the disease.